I'm Courtney Valenzuela, and this is Reinvesting into the Community, Following Reimbursement Trends in Oregon Hospitals. For my project, I am looking specifically at critical access hospitals and how they reinvest their money into the community. A critical access hospital is a smaller hospital. It usually caps out at about 25 beds, and they serve rural and frontier communities. The map on the screen shows all 25 critical access hospitals that are located in Oregon State. And these hospitals maintain a tax-exempt status with the expectation that any profit that is made is redistributed into the community. However, reinvestment is discretionary, and many hospitals contribute varying amounts back to the community, even though reimbursement was mandatory. Other hospitals tend to keep money in-house, claiming that they're reinvesting into their quote-unquote Medicare community who is seen at their hospital. So for my proposal, I am looking to see whether critical access hospitals that exist in the same county as a free clinic offer more or less funding back to the community. The literature talked a lot about unmet needs of the community, and while this concept was not explicitly defined, it can cover everything from a population that is uninsured in the state to different counties that might not have adequate access to prenatal care. It's not a surprise that the rural counties have the highest number of unmet needs, and this is often due to the fact that they're working with such limited personnel and resources within their healthcare systems. Unfortunately, without adequate access to ambulatory services or routine care, many of the treatable illnesses become uncontrollable and result in hospital visits. A lot of these hospital visits could have been prevented if patients had adequate access to routine care or preventative care, which I think it's important that resources like these free clinics or subsidized clinics are critical when it comes to stabilizing the healthcare services for underserved areas. And so having a free clinic in the same county as a critical access hospital should not reduce the amount of money that's invested in the community, but increase it to help support this type of safety net program. Although I can't be 100% sure where the money is going, I hope to find some relationships between the amount of money invested into the community and the number of free clinics or subsidized clinics that exist in that county. Research design. So here's a little bit about my sample selection. I integrated two different data sources from 2016. The first one was looking at critical access hospitals. There are 25 in Oregon, and they're located throughout 20 counties in the state. Each critical access hospital had at least 2 free or subsidized clinics located within the same county. And there are 270 free clinics located in the state of Oregon. So my independent variables, things that I think would be affected or would affect the amount of reimbursement, would be the number of free clinics in a county. As the number increases and there are more resources available to the community, I think the amount of funding that a hospital donates would go down. Next is the percent of reimbursement. Some hospitals might offer a fixed level of reimbursement, such as 10%. Any capital projects, so any big repairs or renovations that the hospital might do is definitely going to affect the budget and how much money they can put back into the community. And lastly, the type of free clinic. So the 270 includes health services such as school boards, Indian health services, and tribal clinics. So while they exist in the community, the general population might not have access to them, which I believe can affect the amount of funding that a hospital puts back into the community. My dependent variables was reimbursement, which was measured in percentage. And I think that the percentage of reimbursement is going to be affected negatively by all of the aforementioned factors. We have already talked that I'm going to redo a lot of my proposal next quarter, but I figured I'd kind of walk you through some of my logic and see if maybe this will help you diagnose where I'm kind of missing the point. So when I first had the idea for this proposal, I thought that I could take the percentage of community reinvestment that the hospitals reinvested into the community and divide that by the number of clinics that were in that same county. I don't know how to do this in Excel or even start to set up this equation, but I know that it didn't really fall into your requirement of a t-test or a ANOVA. So to satisfy that requirement, I ran an independent t-test comparing the high and low reinvestment for hospitals using the mean of 12.7%. Anyone above that was considered high investors into the community. Anyone below that was considered a low investor. And the results are in the lower right-hand corner. I'm not sure that they're super helpful to my proposal, but I put them there in case I'm missing something. Another concern I had with my data was at this point I haven't incorporated any information about how many free or subsidized clinics are in each county. I'm not sure if that's coming up in 552, but it does make me a little nervous that I haven't incorporated a big piece of my data yet. And the third fault that I'm finding with my data is counties might not be the best unit of analysis. The example that I put down below is Clatsop County, and as you can see, I don't know who drew this boundary line, but geographically it doesn't make a lot of sense to have that represent one county. And I think that if I'm running my data based on a unit of analysis of a county, it's not going to give me a very good depiction or representation of the results of who's donating what amount of money and where these resources are really located. Findings and implications. So I think the biggest takeaway that I had from working with this data set was that even though it was required for critical access hospitals to reinvest any profit they made back into the community, they all kind of invested varying amounts. The graph at the bottom there shows the 25 critical access hospitals in Oregon and the amount they contributed as a percentage of their total patient revenue. So in the middle there, we have Peace Health and Peace Harbor, which are at the lower end. They donated about 0.8% of their total patient revenue. And I believe the highest contributor was Providence Hood Memorial, and they had 24% of their total patient revenue. The red line in the middle represents the statistical mean or the average, which was 12.07% that was donated back to the community. The data I've analyzed this quarter is useful as I start to refine my focus on critical access hospitals and resource clinics. While there are many factors that influence hospitals and how they spend their money, community investment is a more complicated matter than I thought. Rural health systems are a fragile entity, and while I still believe that money should be invested in preventative medicine for the community, I also have a better understanding of how the scarcity of funding can lead to bankruptcy for a critical access hospital. Whether or not hospitals decide to invest their money into free or subsidized clinics, I think it's important to remember that resources are limited. And to ensure the best possible outcome for the patient, these two need to work together.